Distinguished guest, Chairman, Board of Directors of the Gamini Korea Foundation, Session Chair, esteemed panelists, ladies and gentlemen, thank you for being here for this afternoon session by Dr. Palitha Abeykoon and Dr. Saroj Jayasinghe on the healthcare sector. The healthcare sector session will be delivered by Dr. Palitha Abeykoon, an esteemed healthcare professional, advises the World Health Organization and contributes to global health initiatives. With a distinguished career, he has achieved numerous awards, led WHO roles, and actively shaped health policies in Sri Lanka, demonstrating a commitment to public health and medical education. Professor Saroj Jayasinghe is a professor of the Department of Clinical Medicine, Faculty of Medicine of Colombo, Sri Lanka, and is an honorary consultant physician to the National Hospital of Sri Lanka, Colombo. His expertise spans clinical teaching, health equity, and complexity sciences. In order to commence today's session, I would like to introduce the session chair. Session chair will be Dr. Saroj Jayasinghe, Senior Additional Secretary and CEO, Climate Change Office of the Presidential Secretariat. The panelist will be Dr. Vimal Karannagoda, Chief Operating Officer and Director of Medical Services, Professor Mrs. Amala De Silva, Professor of Economics and Health Financing, University of Colombo, Dr. Sarath Samarage, Institute of Health Policy, former DDG Planning, MOH, Dr. Anuji Gamage, Senior Lecturer, Consultant Community Physician at the Paraclinical Department, Faculty of Medicine, General Sir John Kotalawala Defense University, and also Dr. Susi Pereira. She's supposed to be here. Yeah, she's on her way. So, Deputy Director General Public Health Services, Ministry of Health, Sri Lanka, President, Perinatal Society of Sri Lanka. So these are our panelists. In order to commence today's proceedings, I would like to play a small introductory video about the Gamini Korea Foundation and its Sri Lanka Innovators Forum. I hope you enjoy it.
The Sri Lanka Innovators Forum, SLIF, is an initiative of the Gamini Korea Foundation aimed at meaningfully contributing towards resolving the complex economic issues confronting the country today. The Gamini Korea Foundation was founded to take forward the passion of Dr. Gamini Korea to achieve just and equitable economic development in all countries. The late Dr. Gamini Korea was an internationally renowned Sri Lankan economist and an outstanding product of the universities of Cambridge and Oxford. Born on the 4th of November 1925 to Dr. C.V.S. Korea and Freda Korea, sister of Sir John Kotalawala, the then Prime Minister of Ceylon. Dr. Gamini Korea's grandfather and granduncle were the famous freedom fighters from Chilo, Victor Korea, who was a member of the Legislative Council of Ceylon, and Charles Korea. His uncle, Sir Claude Korea, was at the forefront of Sri Lanka's entry onto the world stage at the independence and for many years thereafter. Gamini Korea was educated at the Royal College Colombo, after which he started his higher education at the University of Ceylon in 1944, before going to study at Corpus Christi College, Cambridge, and Nuffield College, Oxford from 1945 to 52. There he obtained 2 BAs and MAs from the University of Oxford and the University of Cambridge, and a DPhil from University of Oxford. He was the first Sri Lankan to obtain a doctorate in economics. He was also the first Sri Lankan to obtain a doctorate from Oxford University in any subject. He was a key member of the Planning Committee for Sri Lanka's first 10-year plan, 1959, which sought to raise economic growth and reduce poverty. Among his numerous achievements was his appointment as the Secretary General of the United Nations Conference on Trade and Development, where he negotiated the terms of the Lome Convention, a landmark agreement providing development and access to European markets to Africa and the Caribbean. He was an early proponent of the equitable development who worked tirelessly for trade and development in developing countries. The Gamini Korea Foundation provides opportunities for meaningful economic engagement through rigorous multidisciplinary research to promote inclusive and sustainable development. The Gamini Korea Foundation, an autonomous non-profit institution, is committed to making a real and lasting difference in the lives of vulnerable people. The Sri Lanka Innovators Forum, SLIF, has been conceptualized by Gamini Korea Foundation to bring about change and infuse innovation into the processes of democratic governance and sustainable economic development. It aims to pursue in-depth research and dialogue, focusing on core sectors that need to be addressed and suggest innovative, results-oriented policy strategies to resolve the current economic crisis. The Sri Lanka Innovators Forum will bring together the like-minded thought leaders and industry stakeholders to discuss, debate and agree on pressing issues in a variety of sectors and devise alternative, sustainable economic models, processes and practices. A group of thought leaders who are also subject experts have been assigned to review the issues papers and provide necessary guidance and relevant research material to the respective authors. SLIF will transcend boundaries and barriers and invite specialists from all over the world to contribute their expert views and knowledge to enable Sri Lanka to face its current challenges effectively. 20 identified sectors have been assigned to experts to research and write issues papers on contemporary issues which have an impact on socio-economic development. The discourse will commence with questions that should be raised on good governance and administrative reforms. The other topics are tourism, export-oriented industrial development, macroeconomic policy, poverty reduction, reforming Sri Lanka's state-oriented enterprises, Sri Lanka's electricity and petroleum industry, Sri Lankan food crops, livestock and fisheries, transportation and highways, education, healthcare, shipping and logistics, international trade and investment, subnational policies, environment, women and development, ethnicity and socio-economic development, information technology and foreign policy. The outcome of these issues papers forms a blueprint to be presented to policymakers as a landmark contribution from the Gamini Korea Foundation towards strengthening the economic recovery of Sri Lanka. You are invited to join the Sri Lanka Innovators Forum by logging on to the Gamini Korea website. Fill in the registration form, choose an area of expertise where you would like to share your knowledge, advice and comments on the issues papers posted under each thematic area. Sri Lanka Innovators Forum, beyond the barriers of tradition.
Thank you very much. I now have the honor and privilege to invite our Deputy Chairman, Dr. Harsh Athurupan of the Gamini Korea Foundation to deliver the welcome speech. Over to you, sir.
On behalf of the Gamini Korea Foundation, let me extend a warm welcome to all the participants in the audience. The video gave some idea of what the Gamini Korea Foundation is doing and actually what the foundation is. And this is, I think, the 16th session that we have had across the many topics that were mentioned in the video. And this is a topic that is of great interest and importance, particularly because in the last few months it's been in the news a lot and not always in a positive way. So we are looking forward to the paper that is being presented by the two researchers. And then we are looking forward also to seeing their policy recommendations. And then, of course, we hope that those policy recommendations, some or all of them, will be able to go forward into implementation, particularly in the next few months. So let me ask Sohan, who's our MC, to come and welcome the panelists.
Thank you very much, Doctor. I would like to invite Dr. Palitha Abeykoon and Dr. Saroj Jayasinghe to deliver their presentation. Over to you, sir.
Thank you very much. Good evening. Distinguished ladies and I won't address individually all proper things. It is a privilege for me to make a short presentation, very short presentation of part of what Saroj and I have done with regard to some of the issues in the health sector. I will give the background and the context, and Saroj will go into the more complex issues and we'll discuss them. But basically what I was told by Sohan is that this is for you distinguished invitees who are coming here to get their views on the paper that we had written. I'm particularly happy that this topic is chosen, going beyond borders and everything else. For example, Anil here is a person who has really gone beyond the borders. He's been in health all the time. Now he's gone to a much larger area of climate change, so to match each other very well. So I think Anil would be able to contribute a lot to enrich this discussion. But I'll start with your permission. I'll start off now. Now, I'm sure some of you would have read this somewhere. From the health system perspective, key factors that emerged were long-term and above-average investment in financial and human resources for health, especially in primary care. Strong political commitment to good health and the whole population. A high degree of community involvement and equity of access and use. In addition, each country had enacted policies beyond the health system. Please, if you don't mind, just note the words in italics. Implementing wide-ranging policies which address many different determinants of health with a particular emphasis on expansion of education, especially for the girls. Now, if I ask you where this extract came from, maybe some of you might recall, but some of you may not. And it actually came from, it's an extract from a report by the Rockefeller Foundation on the topic of good health at low-cost countries, GHLC countries, published in 1985. The remarkable thing is, I think it holds true even for today. And it's good for us to look back and look forward and see how far we have come and whether we have made any significant improvements in terms of the system. Certainly there are many results, many achievements that we have made, but in terms of the system. And that might also mean that we don't have to change the system too much, and that's the kind of question I want to raise. Then, when I talked of the good health at low-cost indicators, now this is a summary, I think this is on the WHO, health indicators Sri Lanka relative to the good health low-cost countries and selected countries, number of countries like that, the four initial countries and this. The remarkable thing is Sri Lanka stands out in any company like this. And some of these countries are economically richer than us, but nevertheless, except for maybe Cuba, which has had a tradition much longer than ours, we look very good. Now, having said that, recently, I read this recently, but this has been some time ago, I read this, I'm sorry, I don't know how this works. How do you go back? You can this, This one, no? I read this note from, in one of the, not recent, it's a journal of 5-6 years ago. It says, despite sustained outcome data, some recent commentators have argued that Sri Lanka is no longer providing good health at a low cost. And the two researchers, so Chapman and Dharmaratna, who's professor of community medicine in Peradeniya, highlighting relatively low health investment, the increasing gap between a system designed to treat infectious diseases and provide MCH services, and the health needs of a country undergoing epidemiological transition and an increasing private sector role in healthcare delivery. All are increasingly contributing to equity and access challenges. Now, one thing we should do maybe this evening is raise this question and see where we are, whether this is actually the case. I'm not going to give answers, Mr. Chairman, I'm just going to raise the issues and then I'll leave it to you to decide what is good and bad. Then, this is a summary of the current status of our health sector and its performance. The role of the state health sector, which is very, very large, particularly with regard to inpatient care. Almost 95% of the inpatient care comes from the state sector. And it's a tax-based system, pro-poor, and efficient. We believe it is efficient, but one might put a question mark at the efficient right now because we are not 100% sure, and our economists who are here will maybe make a comment on that. Right now we are feeling resource strained, and the role of the private sector. Role of the private sector today, of course, that what we know is that about 50% of the outpatient services, the ambulatory care services, is by the private sector. And about 3-4% of the inpatient care, maybe 5% at the maximum, is by the private sector. But in terms of the costs and the amount the people pay, private sector is almost the same. So that's an issue that we need to understand. And the relationship of the private sector to the government sector, as you know, state sector, as you know very well, is very tenuous. With regard to human resources, particularly our consultants, the doctors, etc., many of them will not survive without the private sector, the government, state sector doctors. And the private sector cannot survive without the government doctors. So that's another issue that we need to consider. Not only doctors, now this goes into the areas of nursing and the other ancillary services of health. All those are really having this issue. Whether it's a good thing, correct thing, that's a debatable thing, but nevertheless, that's a reality. Then, of course, sorry, I'm very sorry. Yeah. Then the curative care services, we have different tiers of this, primary, secondary, to tertiary and teaching hospitals, etc. The out-of-pocket expense is another issue that we should take up. Right now, if I am correct, Amala, I think it's almost 50-50. 46 it varies between 45 to 55, but right now it is about 50-50. That means people pay 50% of the health expenses that people are actually out of pocket. They pay out of pocket. Now the argument is that it is not so bad in Sri Lanka, is that the out of pocket expenses are coming mainly from the rich sectors. But I don't think that is really true right now. We have evidence to say otherwise, that certainly it is coming from the rich because the private sector is used mainly by the relatively rich population. But nevertheless, even the poorer people, with regard to laboratory tests, medicines, it's becoming quite high. And that's another issue that we need to take up in terms of the policies that we formulate. Then, of course, preventive services, these are they are good. We'll come back to that. Defined areas are doing quite well. Now we have a declining morbidity due to communicable diseases, which was our mainstay in terms of morbidity, say, 30 years ago until about 15 years ago. Now the transition has taking place, and now the morbidity is dominated by non-communicable diseases, what we call NCDs, and to that we include also mental health, and also road traffic injuries. So all those things, if you basket them as NCDs, they contribute almost 70 to 80% of the morbidity and also 70+% of the mortality. Most of this you know, but there are issues in each of these. Then we have the emergent diseases, dengue. I put pandemics here. I mean, there are no pandemic right now. We just got through a pandemic, but the potential of pandemic exists, not only in Sri Lanka, globally. So that's a concern. That it's a global concern, and certainly it's a concern that will have to be addressed in Sri Lanka also. And the other issue is our fast-aging population. And if I show you a graph, yeah, I'll come back to that. Yeah. I'm sorry, I'm not handling this properly. My finger is touching and it's moving. No, it's okay. No, it's okay. It's okay. It's okay. Thank you. Yeah. These are some of what we can consider the emerging challenges. Local issues would be something like severe socioeconomic crisis and the problems of health financing. An unprecedented pandemic, we just got over it, but it has left a lot of residue challenges. A rapidly aging population, change in disease burden, and these two, loss of confidence in the health system among the people. Somebody mentioned this, that in recent times there has been so we have to build up this credibility, and that's a challenge that the ministry, particularly the state sector, has to build up. And we have people who are directors of hospitals here. They will address this issue and give us some comments. And then, of course, migration. Migration, of the health personnel, in terms of numbers, it's mainly the doctors and the nurses. But because other categories are small in number, the base is very small, any movement of the other categories also leaves a big dent here. Now, doctors per se, we have to have, I'm sorry to say this, but we don't have exact numbers of the doctors who have migrated. We can't get the numbers. We have estimates and close sort of guesstimates. We don't have a specific number that we can get from the Ministry of Health. That's an issue also. The health information system, how accurate it is, and how real time. We don't have real time data like this. But from all estimates, we have had about 1,000 doctors leaving the service in the last 2 years. And I look at from the receiving countries. Now, we are a big source country, but receiving countries like UK, Australia. Now, in Australia, I got information from the guys in Australia whom I know, that Sri Lankan doctors are the fourth migrant doctors to Australia in the last year. UK, we were not in the top 10, but now we are in the top 10. The 4 countries our doctors go to mostly, as you know very well, are UK, Australia, New Zealand, little bit to Canada, and to the States. States is much less now because there are some restrictions with regard to the accreditation. But that is also, we cleared that, so now that is also becoming easy. We managed to get the accreditation of our medical council, which will enable our doctors to go to the States also. Whether it's a good thing, bad thing, that's another debate because our doctors wanted it. So migration is an issue. What do you do? The kinds of incentives or disincentives that you can introduce in Sri Lanka, they can help. But the reasons, the push factors are quite strong right now, that it may not be possible for a country like Sri Lanka to stop it entirely by incentives and disincentives, unless suppose you ban the whole thing, that which is not also going to be possible. But there are other issues that come up from this. Now, WHO has a code of conduct for recruitment of personnel from developing countries. All the countries have accepted that. It's not law, but it's ethical, it's a convention. And we have signed one with UK. The WHO one is a multilateral one. With the UK, we have signed a bilateral one. I learned that is only for nursing, not for medical people. And those codes of conduct are good, but there are simple ways of bypassing those, getting around them. For example, UK, they may not recruit directly, government to government from government, but they have agencies which recruit. Who are not bound by this. So it's a difficult thing if the country that is receiving the doctors want to get doctors. With England is tremendously short of doctors. In fact, they changed their medical education system to make it easier to produce doctors, like apprenticing, like Hippocrates days. Basically, Saroj, you can go through without all these other exams and the system that you do. So, because they are very tight pressed to get some doctors out quickly. So, if they produce enough doctors, then of course the migration from Sri Lanka will tail off, or like in other countries. I presented something at the Prince Mahidol conference last week on migration alone. We had a panel with some other people who are now region. If you only work out the doctors who have, I'm taking doctors, but when you add the others, it becomes more. Minimum doctors who have left Sri Lanka in the last 6-7 years, if you told the number, and you take something like 3.5 million rupees to produce one doctor, which I think is more, but we can let us take the base value, then it works out about $4 billion of transfer money from our country, summa to the developed countries. We got nothing back out of it. It's a huge, it's a freedom to travel, freedom to move is all that is important, and we have to respect that. But nevertheless, there's an issue here. So, and what we are trying to now do is to get some of the Asian countries to adopt a more stricter resolution with regard to migration, so that now, if we can't stop the doctors and nurses going at some point, not all go. We have done enough surveys here. About 30% of the medical students in Colombo and in Peradeniya, they express desire to leave when they graduate. But that means 70% are going to stay. So that's to me, that's a positive thing. we should try to work, we are trying to work out a agreement where these receiving countries will help to improve our nursing and medical, particularly nursing education and medical education. Dr. Susipera is coming. So whether that will work, I don't know, but that is the plan. Then, of course, we also face global and regional issues. I'll go very quickly. And these are very well known to you: climate crisis, economic performance, conflicts, geopolitical. That you all know this better than I. And this is what for those of you who are not familiar with this, this is a basic, this gives a basic idea of where we want to go. This is called the PHC, or Primary Healthcare Cube. For UHC, for universal health coverage, we use this. The 3 dimensions, one of which is x-axis, is really on one side is the population that is covered by health. Ideally, 100% should be covered, but rarely that 100% is covered in any country. Then the services which cover the services which are there to cover these people, ideally 100%, but it is never 100%. Sri Lanka it is getting less, I think, and the delays are getting more. There are issues there, and of course the vertical axis is the amount of money people have to pay. How do we fund the services, and what are the costs that we have to bear? So ideally, this blue cube should fill the box. This cube, the blue cube should fill the entire thing, but it will never happen, and there's no country in the world. But that's aspiration. Who is covered? What services are there for them? And who is paying the money? Those are the 3 issues that ultimately will sum up where we are. Now, this is a simple thing which indicates the change in population. Those demographers among you will understand this more. Now we have about, I think, World Bank figures and WHO figures at 12% of our population is over 60 years, 65 years. It will be about, and the population that is over 60 relative to the population under 15 is about 40 to 60. In, say, 2050, it will be something like 50 to 150. 50 children now under 15 will be matched by about 150 who are over 60. So we can understand immediately the issues that are likely to come up, which means NCDs will be predominant. There will be all kinds of non-communicable diabetes, hypertension, all the other diseases that come with it, mental health, Parkinsonism, dementia, cancers, and all these, as you will know, since you have experience in it, these are the diseases that will break the banks. They are the most expensive ones. Anything that is communicable, it's like it goes like this, top, finished. These are things will keep on hanging around until practically end of life. So these are diseases that are very, very costly. And the challenge would be for countries like how do we manage that, which means now we are trying to see that, so Susi will make a short presentation, I think, later on. How do we prevent, her main theme is coming, so I wanted to do that. How do we prevent? The only way to, prevention is not, you are not going to prevent forever, no? At some point in your life, you are going to get any of these diseases. But what we are trying to do is, if a person gets an angina or a heart attack at 40, 35, 40, we would like to postpone it to 75. Similarly, the other diseases. Then you gain a lot of space, and then you can recover, the economy can recover. These are and this is the important thing again, financial challenges. These are very important for us, and we should really look at this seriously. Some of you, because you all are economists and who know this business better than I, we obviously have insufficient resources for health, clear. And we know that there are many inefficiencies, both in terms of allocation and the technical services we deliver. We know there are inequities. We have the need to reduce the catastrophic as well as the impoverishing health expenditure. Catastrophic is if the general sort of definition is if a person has spent more than 10% of the income on health, then poorer families, it is more important in the poorer families, it is catastrophic expenditure. And and the out-of-pocket expense, which I said is quite high, 50% of the total health expenditure. And the need for greater synergies between the private and public sectors on health towards university health coverage. Now, this is an arguable thing. I mean, there will be different points of view with regard to this as to how the two should mix. That is not, that jury is still open as to how it should be synergized. But I feel ultimately we have to make some choices, and say places like Jawadanpura where you have some system like that, we'll have to examine that a little bit more carefully to see what the pros and cons are, how it can be used to our advantage, reduce. I'm going to finish now. These are, for most of you, this is old hat, the building blocks of the health system, health services architecture, the way it is delivered, and we'll talk about the delivery model a little later. Financing, I just mentioned that. Health workforce, we touched on that. Other one is medicines and diagnostics, and this is, of course, what gained a lot of newspaper space in the last two, three months or last year. The point I want to make is we have a very strong National Medicines Regulatory Authority. In fact, I can tell you, because I was part of the development of this, it's one of the strongest NMRAs in our region, certainly. In fact, we have included there that we can make decisions on the basis of need. There's a need clause as well as a cost benefit, which most regulatory authorities don't have. And people are surprised that we were able to get that included in that. So if we actually follow that NMRA, even 90% of it properly, these scandals that now we are talking about, it cannot happen. All those are accounted for in that. So we really, it's a question of governance. It's not a question of lack of law, lack of knowledge. It's a question of governance. Then, of course, health information, very important, and now it's becoming even clearly more important with the AI, advent of AI, and that's now catching up so fast. There will be so many things that we can do. There are so many things that will be problematic. And we have to study this very carefully, and I think the ministry is now thinking of doing some work on this. And the issue of governance, which is an overall thing, it covers practically everything that we need to do. And I'm going to stop there, and we'll wait for your comments, and I'll get Saroj to complete this. Most of these are Saroj's. I'm presenting on behalf of Saroj. Come, Saroj. Thank you very much.
Thank you very much, sir. Thank you very much for inviting me to make this short presentation. What we've done is to raise some crucial issues and try to elaborate on some of the problems which are facing now, and that's what Dr. Palitha Abeykoon has done over the past few minutes. And over the next few minutes, I will try to propose some of the interventions we have thought of. Now, what's interesting is, if you look at the history, there's almost everything what we are going to say has been told some time ago, not recently. For the past 40, 50 years, we've been telling the same thing. And that is the issue. If we are really to go forward, why is it that we are not changing this so-called system? Because it's all there, or someone has written about it before. And we will focus on areas where we have some expertise, that is in the health, about health care and so on. And there are certain areas which others have to help the health sector. For example, financing and the economics of it. If we try to do it, we are not really experts in that. So I think this is just a beginning, or another beginning of this path which we have been taking for several decades. So we've looked at the interventions under these headings, and you'll notice that these correspond to the building blocks. Dr. Palitha Abeykoon described the building blocks, and we are almost, it corresponds almost 100%. So let's take each of these, and I'll pick out a few points, and hopefully we can begin to use those as discussions. And policies cannot be made within a few months. I think it's a long process, so I think this is another process which we want to begin. So we've looked at it from a macro point of view, and the need to have some sort of policy direction is important, and towards that there have been recommendations of having a National Health Commission like the National Education Commission. And right now, the Secretary of Health, Dr. Mahipal, has convened a think tank. So that's a step in the correct direction. And in fact, there's a meeting coming up. The second meeting is coming on the 2nd of February. As regards to efficiency in administration, one key area is this overlap between the ministry, which should be making policy, and the Department of Health Services, which should be the implementing arm. And we all know that it's very close to each other. And the recommendations whether there should be a distance has been made by Dr. Shelton Vanasinghe way back in 1980s. And so that's an area we have to rethink. And if we don't want to, if we want to continue as things are, then that's a different issue. Participatory decision making is something which we pay lip service. We really don't have participatory decision making at the top. Even in hospitals, it's mainly there are certain patient groups, but there is no formal participatory decision making. And if we are to learn from the Aragala, that was one crime, that was one major demand, that the voices should be heard. And if you look at the health and many other sectors, their voices are not heard. No structural way of interactions with the citizens. As regards to empowering public, there are patient charters which have been proposed, and also whether health should be a fundamental right. Not health care, not emergency health care, but health as a fundamental right. Governments are very worried about that, because whether they be taken to courts due to violation of fundamental rights. But that's where, if you look at the literature, you find countries have have addressed that issue by allowing the state to, within reasonable allocation of availability of resources. It's not that someone can suddenly come and say, I want a bone marrow transplant, and if I don't get the bone marrow transplant, my fundamental rights are being violated. That's not the path we have to go. We have to look at it from affordability also. So that will be left to the courts to interpret in a sense. Then the final point is that there should be policies which don't change with each government. Again, these have been told repeatedly. In almost every forum we say that, but it doesn't happen. So there you are. So for governance, these are some of the areas we thought of, and also in relation to into more autonomy being given to institutions like hospitals, and more autonomy being given to the provinces in capital investments and so on. Those are some of the areas which have also again been recommended previously. In relation to efficiency, one key area is health technology assessment, which we really don't have, and we have the experts here. So Anuji is an expert in that area, and even in our faculty in University of Colombo also, there are people who have looked at this. Models are available in Thailand, which has implemented health technology assessment. Basically, when a new technology or new intervention comes in, it is not only the doctors who should be deciding whether it's effective or not, but we have to bring in the cost. We have to look at the cost benefit, the societal impacts, and the technology per se has to be evaluated. And in the UK, they also brought in the NICE, the National Institute for Clinical Excellence, which looks at these, and there are large teams which will evaluate each new technology. So technology does not mean just drugs. For example, it might be an intervention like bone marrow transplant. Can Sri Lanka afford it? So then you'll have to look at the incidence and so on, and agree what we should be doing. In relation to efficiency, another area is to forge stronger links with social welfare, because in a sense it's improving the efficiency of the health service, because right now the social service sector is separate from the health sector, and care is provided by the health sector. When a person goes home with a chronic illness, for example, we don't have a system in Sri Lanka to support them. It's mainly, they have to come to the clinic. So even if you are amputated and at home, there is no one who is going to provide officially any sort of support. So that's in relation to efficiency, health technology assessment, and certain reforms to improve efficiency. Mobilizing resources, I'm not going to go into detail here. I think Amala will be making a presentation on this area or commenting on this area. But we looked at certain things like strategic purchasing, sharing of resources, and pooling of resources, and using public as well as private resources in an efficient way. As mentioned by Dr. Palitha Abeykoon, it's a symbiotic relationship. The private sector will crash if the state sector does not send its personnel. The state sector can survive, I think, even if the private sector closes down, but not the other way around. Not the other way around. Okay, now when it comes to service innovation, I'd like to look at this in bit more detail. Now here again, we have Dr. Susie Pereira who's here. She will make some comments on this. There are several service innovations which have been proposed. One is the primary health care. Now right now we have prevention and primary health care being provided by the MOH. That's the Medical Officer of Health. We started that in 1926. Kalutara was the first area, an administrative area, which is being looked after by a MOH and a team, public health inspectors, nurses and midwives. Now you wouldn't have noticed this group until COVID hit us, dengue hit us, and so on. Because the people who have a certain amount of affluence or money will access private sector for most of their services, and you wouldn't go to the MOH. But Sri Lankan people, a vast majority, depend on that MOH services for screening of their children and for pregnancy, nutrition in pregnancy, and so on. So that's the backbone. And in fact, as one reason that we had good health at low cost was because of that MOH system. And that was brought in by the Rockefeller Foundation, and they experimented different models. So you'll notice that it's mainly for maternal and child health. It doesn't deal well with the non-communicable diseases such as diabetes, hypertension, heart disease, and so on. So we need a similar system which will be in the front line, in the community, and they will provide some sort of care for these chronic diseases, screening of chronic diseases, and so on. And that's where Dr. Susie Pereira comes in, because she has championed this curative network of primary care facilities. Now there again it has been proposed, but I may be wrong, but it's not moving. We know it's a good model, but things are not moving. And with that comes shared clusters. You have, just like a area which is under the MOH, you have a set of institutions which are linked and which can, so from the primary level, it can go right up to the tertiary level. And it can provide occupational screening and screening in particular geographic locations like thalassemia in Kurnagal area. Right. So there are several service innovations which have been proposed. Another one is the preliminary care units. If you look at the statistics, Sri Lankans are one of the, we visit hospitals per population per year, we are one of the highest in the world. Admissions to hospital, again we are on the top of the list, or almost there. Right? So if you have to reduce the overcrowding in the hospitals, we have to think of new, innovative ways. And one proposal is the preliminary care units, which will screen patients. What we do there is to focus attention on people who are being admitted and try to sort them out within 24 hours so that they haven't to get admitted to the main hospital. So it's been practiced in other countries also, and certain places do have it in Sri Lanka, but most of the hospitals don't have it. It's only a handful. So again, we know what needs to be done, but it's not happening. In relation to health workforce, now it's very interesting, because if you look at the literature, Simeonov, he came up with this about human resources for health in 1975. It's a fantastic report if you read it, because he's done analysis almost so many years ago, almost 50 years ago. And if you go to the archives of the Ministry of Health, you will see reports and reports on human resources for health. But we haven't done well. We are still struggling with the policies. We are not able to respond to a crisis. There is huge migration. So again, we seem to know what to do, but it's not happening. And Dr. Dilip De Silva, who is a dental surgeon and a health economist in Peradeniya, and they have published this paper where they have actually modeled it. They have got a mathematical model of, I think it's a system dynamic model, which predicts the human resources which are required for health. Okay. In relation to medicine and medicinal products, again, we've got an expert here, Dr. Palitha Abeykoon himself, and he mentioned certain areas, but there's one particular area that is local manufacturing. It's pathetic. We didn't have even saline being produced in this country. If you develop a new medical device, you just cannot get it registered. We know it because we are working with Morotua, and there are several devices you just can't get. There's no system in the NMRA which efficiently looks at a new product, brand new Sri Lankan innovation, to try and approve it. Rational use of drugs, from 1971 we've been saying, because that was when the report came out, Bibile and Vikramasinghe report. So, rational use of drugs, doctors prescribing rationally, doctors using generic terms, and so on, known but not being implemented. In relation to health information systems, we are facing an issue because of data operability. It can't use, there are several institutions which have started their own information systems, and one system doesn't speak to the other system. So again, there's something which we have to work towards, and with that, hopefully, the health cards would come in so that we can have the information in something like a credit card, and you carry that with you. So there are several reports that have given the references. International relations, it's another important area, and we will face certain issues in relation to the service sector, because there will be countries which will want to open the service sector to open our service sector to other clinicians and so on in other countries. And again, this is not an area of expertise which we have, and hopefully we can work with the Lakshman Kadirgama Institute on this area. Finally, we come to some of the climate change and planetary health challenges. So again, we've got the expert here, Dr. Anil Jayasinghe, who will help us in looking at this area. But this idea of planetary boundaries is something very important, because in Stockholm they came up with this idea that the world, that the Earth, the survival of the Earth will depend on 9 major systems. 9 major systems. So climate change, then pollution, then ozone hole, biodiversity loss, water, and so on. And when you look at those boundaries, why are those areas important? Because if it goes beyond, it's a point of no return. Example is climate change. 1.5 degree increase in the global temperature, and we are almost there. If it goes above 2 degrees centigrade, it cannot be reversed. That's why it's a climate crisis. Cannot be reversed means we just after that, it takes off the system. It acts as a complex dynamic system. It has its own momentum. And the weather patterns will continue to change, and we won't be able to bring it back to normal. So in this sense, this idea of planetary boundaries have been identified. So we'll have to work towards those concepts, and the health system will have to embrace these areas. So that's the list of interventions which we propose, again as starting points for discussion. And now may I call upon the rest of the team to do what's in store for all of us. Thank you.
Thank you very much. I would like to invite our authors to take their seats, as well as our session chair, Dr. Anil Jayasinghe, and panelists, Dr. Vimal Karannagoda, Professor Ms. Amala De Silva, Dr. Sarath Samarage, Dr. Nanuji Gamage, and Dr. Susi Pereira to take their seats, please. I would like to invite Dr. Anil Jayasinghe, our session chair, to commence with the panel discussion. Over to you, sir.
Thank you, Shahan. Ladies and gentlemen, now that you'll have listened to 2 presentations, I think, I hope that our experts in their respective fields areas of expertise would do the justice to the presentations. Now, as just to start the proceedings, we know that health is wealth. And then we have to ask the question, how wealthy is health and how healthy is wealth. And we know that anyway, health is not only for wealthy, it's for all. So that's the idea. And I thank the Gamini Korea Foundation and the Innovator Forum for organizing this series of issue papers. I know Dr. Lloyd Fernando started this, and I also had some discussions with him. So I think all in all, the Gamini Korea Foundation can sort of work out a holistic approach on development paradigm of the country. So I would like to first introduce the panel. I will not go by seniority. I will first I will introduce those who have worked with me from so I had some other here. Now Professor Saroj. Yeah, as you know, is the professor of Department of Clinical Medicine, and he is well-known expert in public health and medical in health equity and complexity science. I still remember somewhere between 1990 and 1995. I read a article written on a local journal on health economics. I believe the economists will not won't be unhappy about that. So I think so that was some long years ago. And then of course we have I don't see Dr. Vimal Karandugoda. It's not coming. Yeah. So then Dr. Sarath Samarage, of course, he is everywhere. He's in St. John's Ambulance, the current chairman. And then he was involved in very many organizations in certain work. And he was the Deputy Director General of Planning when I was probably the Director of the National Hospital and Accident Service. So, and also he's the current President of Association of Medical Doctors of Asia. And of course, Dr. Susi, I think she's the everlasting Deputy Director General Public Health Services too. I think you have been batting so long in this position. Yeah. So, and of course, my contemporary, we studied together in the PGIM. Of course, I think Dr. Palitha Saroj talked about her expertise. And last but not least, Dr. Anuji. I remember when I was DG, she was about to leave to KDU, and now she has settled there, and she's a senior lecturer, consultant committee physician at the paraclinical department. I think you are working at KDU. I think you are working for planning, right, in the ministry? Yeah, I think you're planning. So, and then of course, I go on to, I used to call Dr. Amala, but now I have to call her Professor Amala. Today only I got to know because I was away from this area for so long. And of course, if it is about health economics, it's Professor Amala. And I don't know why others don't come out, but for some quite long time, she has been engaged, heavily engaged in health ministry work and with the development partners and doing various studies on health economics. And of course, not to forget that she was one of my supervisors in MD thesis. And then, of course, last, Dr. Palitha Abeykoon, one of our gurus, and everybody knows about him, and he worked for WHO, and his forte, I think, was health education, but then he has worked on other areas as well. So I thank all the panelists for coming. I only miss Dr. Karandagoda, who is also a good friend of mine. Now, going by the format given to me, I would ask each panelist to talk on, sort of comment and come out with ideas, comments, or questions, or the question these two gentlemen, based on your core competence. So I would like to probably start from Dr. Samarage. Actually, you are given 10 minutes. I was told 10 minutes. Of course, you can consume your time, but then if more time is left, then we could discuss more. So I just glanced through this issue paper. This was a PowerPoint presentation today by two of you, but I hope that all of you would have gone through the issue paper. So, Dr. Samarage, over to you.
Thank you, Mr. Chairman, for the kind introduction, and thank you for the Gamini Korea Foundation for organizing this event and inviting me to be a panelist. And talking about the issue paper on health sector, a very comprehensive issue paper, covered most of the priority areas and how do the challenges and the interventions relate to the SDGs. So I see that the paper is very broad, and it's a sort of a conceptual paper. But we need to focus on the issues. It's focused on we are focused going on to interact with the policymakers and give them these issues. Therefore, we need to identify the problems or the issues at hand. Rather than, we have been talking about most of these broader areas, but unless you identify really what is the problem and then analyze it and find out what causes it, until you do that, you will not address the problem. So this is happening in our system. I will give you a couple of examples briefly. First one is a lot of things were talked about governance. One example is from the top, other example is from the bottom. Why I say that we need to focus on the problem really. One is about the governance. We need to really focus and see what in governance that is wrong or that is not happening. So, for example, at the top, the functioning of the health ministry right now. It's important to review the operations and how it is functioning. It's good to study recently, the recent past, the turnover of heads of directorates, which are giving the leadership to the whole country in the health sector. Why it is happening? Why you need to look at that? There's musical chairs happening there. Dr. Saroj Jayasinghe will know why it happened. Why the directorates are the people who are developed to specialized on a subject, and they are moved to another thing. But because the minister wanted 2 people out from their post, so he introduced a transfer system. Every 4 years, they had to transfer. And then see what happens. A person is appointed to a directorate, all are nationally who had to give the leadership to that program. There are about 40 or 50 directorates. Imagine one person you appointed and he is developed, he is trained, he is sent abroad, and by the time he develops the expertise and everything, he is sent across to another completely different area. And he starts the cycle again. Right. So this is happening right now. We need to correct this thing, and we need to really identify this thing. There must be upward promotions and development of people, and we don't have expertise doing that field. We need experts at that point of time. For another good example is we have about over 150,000 employees in the system. The Education, Research and Training and Research Unit was separately created. A Deputy Director General was appointed. I don't know, there's no permanent for the last several years. How can the education, training and research and the development of the human resources happen without a proper head? And at that, all the people who have been there are not experts in human resource development. So we need to have this upward development and people trained in those areas. That is one example I see. And also along with that is this, in management we are talking about the span of control. If you take Dr. Jayasinghe will know very well how difficult for him to manage. There are, I think, 17, or I don't know, Dr. Susi can correct me, or 18 Deputy Director Generals reporting to under the Director General. And I think high time that we need to look at that. In some countries have done that and developed 2 Director General positions for preventive services and the curative services. Then the other issue I want to highlight is from the bottom level. We looked at a lot of things were talked about. Non-communicable diseases are increasing trend, and with the aging, all that. So our Institute of Health Policy, we started the first cohort study in Sri Lanka on health and aging. So 2018-19, we did the first cycle, a nationally representative sample of about 7,000 people we analyzed, and we have the data, and we have already published several papers. Anuji is also part of the system. And from that data we analyzed, and with regard to, we looked at the cascade of care, detecting a person illness, and then treating, and then following up and having the control. Right. So this is with regard to diabetes. In detecting, out of the 100% of diabetics in the country, testing we are doing well. The blue-colored one is Sri Lanka compared to the global. We are detecting the testing is doing that. And then we are diagnosing is also about 62% compared to the global standard of 44%. And then treatment. That also we are doing well. We are treating more 45% of this thing, diabetics who have been picked up. But we are doing very bad in control. We are doing very bad in control. Same picture with hypertension. Hypertension, percent of Sri Lankans with hypertension, if you take this thing, ever screened. From our study, we looked at with how many of them have been screened before. Only ever screened was 87%. Then diagnosed, out of that, 53% have been diagnosed as having hypertension. But only 50% of the diabetics are aware that they have diabetes. Almost 50% don't know that there are people who have diabetes that they don't know. And then, treatment is also quite good. We have a good curative care system, and about 44% of them are treated. And they quite a number of them adhere to the treatment given, but our control is again poor, only less than 20%, worse than India. So there's some problem there. Shows that our detection and treatment, Sri Lanka tends to do better than most developing countries. But on translating treatment to control, we do particularly badly. So we need to really focus on what doctors are doing and rethinking treatment protocols. This we need to address that. So that's my second point. I'll finish with another one issue that was highlighted. A lot of both speakers talked about health financing, and we spend about 1.6% of our GDP. The government is spending on health, and if you look at the health out of the health budget, we are spending about, this from our National Health Account statement, 41% for inpatient care, 19% for outpatient care, and then medicines and equipment we spend about 19%, but we spend only about 5% for preventive care services. This is where we are asking for increasing. We are not spending enough money for health care, but we are asking for that, and there are sometimes it has increased, but most of the money goes for curative care and establishing specialized centers and creating more problems. We need to increase the public health or preventive service expenditure. With that, I will stop. I thank again one for the.
Thank you, Dr. Samaragi. I think mainly you touched upon governance, HR, and finally allocative efficiency. Dr. Amala will later touch upon. I think just to say a few words, governance is the major culprit, I believe, in anything. We are talking about good governance, but this is filthy governance. Otherwise, as Dr. I think Samaragi, or one of you said, this the current issue couldn't have happened unless very bad governance. So no act, no legislation can hold if you are not adhering to basics of governance. So that's it. And then it's actually it's about political hierarchy as well as bureaucrats as well as technocrats. Not only bureaucrats, even the technocrats. We see everywhere this is happening. Now, if you just take presidential fund, which is, I think, they are to address further equity issues, if there are, on top of everything. But I don't know whether anybody has analyzed, but I am sure if you analyze, you will see equity would have been violated by the presidential fund more than anywhere else. I'm sure. You know how it occurred. So that's about those things. And now I would like to move to Dr. Anuj.
Thank you, sir. Good evening. Let me first of all congratulate the two authors for a fantastic paper, and also thank the organizers for inviting me for this panel discussion. So I have extracted a few points to talk from this note to talk on and elaborate on. So these will be healthcare finances, mainly focusing on out-of-pocket expenditure, and also talking on improving efficiency. And then because talking on efficiency gains, we'll be looking at a little bit on screening, how to improve screening, and then finally health technology assessment. So talking about healthcare finances, yes, financing is one of the most powerful policy instruments for determining whether a country ensures affordable access to healthcare. The public health expenditure on health as a percentage of GDP has fluctuated between 1.6 to 1.9 in Sri Lanka. The private contribution to current health expenditure is significantly high, and of which out-of-pocket expenditure is fairly large. Mostly people incur direct healthcare costs on medicines, investigations, channeling, etc. And when you consider non-healthcare expenditure, direct non-healthcare, so they spend on transportation, meals, and accompanying people. So, and then, yes, there are sector-wise variations, and we have seen that well, we previously saw that it is with the higher socio-economic strata that this lies with out-of-pocket expenditure. But now it has shifted towards the lower socio-SES. So experts always talk about public financing is key to universal health coverage. So of course we need more allocations towards health, and earmarking tax, earmarking of sugar tax, tobacco tax, and maybe earmarking provincial allocations will be a good point to start. So why out-of-pocket expenditure is a problem? Because that will impede people from seeking health care and ends up with disease complications. And also ones who want to go seeking health will have to bear the brunt, economic burden. And some people might be thrown into impoverishment and even catastrophic health expenditure. So the classic argument towards why governments should intervene for health would be because we know health is a right. And also market failures like public, so because of goods, public goods, monopoly, externalities, and asymmetry of information, all these arguments. So market failures can happen, so therefore the governments have to intervene. Equity issues to ensure equity and social welfare, and also human capital issues. So morbidity impacts the quality of life as well as the quantity supplied by labor, which affects by reducing productive capacity of any force, any workforce. And death will remove a person from workforce. So therefore we want to prevent these things and improve productivity. So talking about efficiency, we talk about, regarding health, we talk about distributive, allocative, and technical efficiencies. And this is more health for money and more money for health. And so therefore we have talked about in this paper, in this note, about the primary health care reform, and then also talked about preliminary care facilities, and I will give you some evidence on establishing day surgeries, ambulatory services, and also appropriate skill mixes, supply chain managements, and also enhancing pooling purchasing strategies, also improve screening. Let's look at HLCs, screening for our population. So this is NCD screening about, so now Samaras Gazer mentioned about diabetes and hypertension not being controlled, not treated well. Well, we have screening services for these things. And Healthy Life Centers, they provide screening services, but see, from 2016 to 2020, now the percentage screen has drastically decreased. And therefore, when we analyze the benefit to cost ratio, that also have gone down drastically. The percentage screen population has declined over the years, and therefore the benefits to cost ratio has also gone down. Therefore, we need to improve and intervene for this to improve screening program in Sri Lanka. Now, we also calculate the projected cost. Now, to screen 20% of the population, based on WHO-ish 2007, we need only 1,021 million rupees. But to do it according to WHO 2019 guidelines, we need only 777. And so half of this is needed only to screen 10% of the population. So screening is a problem. Why? Because HLCs are not offered after hours, and people are not aware of this. And sometimes when they do go, they don't have drugs, they don't have investigation, they don't have the facilities that we should be providing. So therefore, I am going to suggest, why don't we think about coupling annual increments with a screening like we do in the military. So if we can do that, because we have insurance, we can utilize that. So for all employees, we need healthy employees, healthy workforce, maybe we can do that. And then moving on to day surgeries, day ambulatory services. Now see, in the current scenario, if for 1,000 non-acute hernia repair, the government spends about 170 million per million rupees. Right? But if we do it as a day practice, day surgery, we can save 15 Sri Lankan rupees, 15 million Sri Lankan rupees for 1,000 non-acute hernia repair. Right. So moving on to health technology assessment. It is a policy tool used by the decision makers. HTA can help policymakers to effectively prioritize health interventions and services, improve their quality, make consistent decisions across institutions, across provinces, reduce inappropriate variation, and signal value to the industry. Public participation, which the voice that we have been talking about, this is also a component of HTA. So why don't we utilize this? So HTA has 3 phases. Phase 1, there is that assessment phase. Phase 2, where you appraise and the report goes to the decision maker's hand, and HTA or economic arguments are not the only arguments that we consider during decision making in health. So it goes to the decision makers, and then they implement it, and then that monitoring and evaluation, that cycle starts. Okay, so during a HTA process, the any technology will be appraised for safety, efficacy or effectiveness, economic attributes, social, legal, ethical and political attributes, and countries have used HTA to design benefit packages. So now we just discuss that we can't afford to give everything free of charge. So now if we are to design an essential service package, we can use HTA to decide what services we can offer free of charge. Okay, finally, moving to intersectionality, lens used to ensure no one is left behind. Right? So hierarchies related to sexual orientation, class, race, ethnicity, education, age, they also affect health outcomes. So if we don't address the causes behind causes, we will never solve any of the problems that we have been discussing. That's why we have been discussing the same thing over and over again for decades. So these different dimensions often have a multiplier effect and also affect policy environment and policy implementation. Now, there is something drastically wrong in this slide. Right? So they are coming up with a gender-related policy. So where is the voice? Right, this is an actual scenario and it has been on news. Right? So this discussion should have involved other parties involved. Right, so we actually analyzed one policy related, widely used in our setting to see whether this is gender sensitive. No, it was not gender sensitive, it was gender neutral. We talk about communities, we talk about individuals, but we forget to think about different roles. With that, I'd like to conclude. In the face of scarce health resources, it is critical to set priorities in a systematic way. Economic evaluations is an important criteria in the process of priority setting in health interventions. By priority setting in health should also consider other important social goals such as equity. The path toward UHC should be progressive. Realization is needed, must make hard choices. Any health sector reform should be a teamwork and be inclusive of, carefully thought about and suit our country context. So these are the references to support the note. Thank you.
Thank you, Anuji. I think you brought up one good thing at last point, reforms. That is one area that, we are trying to hide behind the carpet. We don't want to change ourselves. We don't want to change systems. And then we want results. And we want to criticize. So I think that is very important. And then the one thing you said about annual increments binding with this thing, I'm very happy. But you can't touch even, right? So because it's, I think it's about governance and the management and, and how historically we are different, and then about health technology assessment, you talked a lot about, but if you take a simple thing like this, right? If you take amoxicillin, how many brands are available in Sri Lanka? I'm sure over 100. Amoxicillin, how many brands are available in UK? Less than 10. It was a political decision to open up, people to take up business. At one point, somewhere in 1990, opened up floodgates. So then comes to HTA, right? What is our capacity in, assessing whether this amoxicillin good or bad, whether this is PT, whether this is amoxicillin, right? And if you have 5 brands, you can do that. When you have 100 brands, can you do that? So that means we have error in very fundamental and simple things. I mean, you don't have to even go, beyond too much, but then these are basic, wrongdoings that we have done. Now, that's what now we, on one hand, we want doctors to prescribe in generics, right? So you take the generic prescription and go to a pharmacy. How can you find out what amoxicillin brand? It will be the brand that the pharmacist would dispense you depending on his cut, right? So, but in UK, when you have 5 brands and they all meet standards. That's one thing. They all meet standards. There may be subtle statistical differences, but they all meet standards. And then the patient can select out of 5 brands. It can be displayed. Right? So I think these are very simple things that we have made wrong decisions for making a buck or for some other reasons, or supporting some, So I think probably there are a lot of things that simple solutions that we have to think before going into major, positioning of ourselves. Thank you. Now that I think I would like to move to Dr. Amala, because I think all presenters touched upon some way or the other way on economics, but I didn't see any panelist touching on the issue paper, right? So anyway, that's how it goes. So we have to accept. So over to you.
I want to thank Dr. Saroj and Dr. Palitha for a very thought-provoking paper, and the Gamini Korea Foundation for having this event where I have met many friends from different parts of my life. So it has been very pleasant to be here today. So let me talk about what I feel is very... So basically, Dr. Palitha was focusing on the fact that we are having an aging population, and with the aging population, it becomes important to think of human capital formation, that health is a very important way of creating human capital formation. Because human capital is an important method of as an engine of growth, and what we have been doing in the past by focusing on MCH has actually ensured that we have good human capital potential. But then the non-communicable diseases that the paper talks about as a challenge, and this is a challenge to human capital as well, because both morbidity, which affects the labor productivity, and mortality or severe morbidity affects the duration in which people can provide human capital. So it's very important to think about the means of improving human capital through thinking about what can be done within the health sector. We have, as we have been talking about, an effective health sector, but where there are a lot of challenges which we know and have talked about, but which we have not really focused on reform, or where we have taken the move of having reforms, like the very important steps taken to encourage the use of primary medical care units under the cluster system. The health ministry has not really seen fit to give it enough importance, so that many of the population is unaware of what is happening, and nor are any people in the community benefiting by the reforms that are happening. So when we think about, the SDG 3, which ensures healthy lives and promotes well-being for all at all ages, we really must focus on this word well-being. And it is very interesting that the WHO constitution, right back in 1948, also used the word well-being. This word well-being has many aspects, and it's very important that we keep that in mind when we are proposing any changes to the health system, because well-being not only considers physical and mental health, but it also actually puts emphasis on the financial well-being. And the lack of financial well-being is what is actually very much detrimental to people getting the care they need. There's a lot of unmet there's a lot of unmet needs at the moment, because when people can't afford health care, it results in they are not seeking health care. And if you don't seek health care, obviously your condition will deteriorate further. So we talk about universal health coverage as the core of the SDGs, and we focus on equity in access to health services, the quality of health services, and particularly the issue of financial risk protection. This needs to be kept central in the discussion of the health sector, because financial risk protection, as I mentioned earlier, if we don't have people who are protected, who can about getting health care, then we will be having a very serious effect, not only on people's health, but in the long term on human capital and economic growth as well. So the SDGs there are 13 targets, and they are split up as health through the life course, communicable diseases, non-communicable diseases, and risk factors, and the resilient environments, the climate change that was talked about, and particularly the issue of health systems. I think it is very important that health systems are focused on, and because many of the issues we are talking about, the financing, the allocation, the human resource development, all these aspects are focused on in the SDG. So NCDs are of course a major problem, and what has become apparent over time is that LCDs are no longer what we can think of as a rich country problem. Low-income countries and lower middle-income countries have very heavy NCD burdens compared to those countries of upper middle income and high income countries. Of course, the treatment that is being provided mainly is guided by what is happening in the developed countries. So it's very interesting that one of the SDGs actually focuses on the need for medicines and vaccines to be developed in taking into account the needs of the developing countries, because they have very different disease patterns sometimes, and of course very different potential to spend on healthcare. So the other issue, of course, is about the Delhi burden, and the paper does focus on the fact that it's not only the non-communicable diseases that we need to focus on, which is a very major burden within our population, but also it touches on injuries, including road traffic accidents. So when we are thinking about addressing the SDG goals, it's about the importance of reducing premature mortality for non-communicable diseases, prevention and treatment of substance abuse, road traffic accidents. But last of all, which is the one I would like to focus on, is achieve universal health coverage. Here we are thinking about one thing I want to focus on. If I think about the health stock, increasing the health stock based on the Grossman model, it talks about raising the education amongst the poorly educated, increasing wages of the low paid, and reducing the price of healthcare, especially in relation to the poor. Why this emphasis on the poor? It's because as economists we believe in this concept of diminishing marginal benefit. If you're already spending a lot on health, as you can if you have high incomes, or doing the right things if you have the right level of education, then you have already benefited in terms of good health. But the poor, who are challenged by poor education and having low pays, as well as having to face high prices, they are unable to actually take the measures where there could be very significant improvements in their health status. So this brings me to the fact that when we talk about universal health coverage, when we have to be thinking about the poor. So often we have health planning documents have become wish lists. If we look at the SDGs as well, The SDGs are also wish lists, is a very long wish list. So can we actually follow on with this idea of wish lists? Our master plans, the plans we have done for health of recent times, have been long lists of long wish lists, with no concern being put on the fact that we do have resource constraints. So at this point, it is very important that systematic costing and budgeting is imposed with planning, that we really have to prioritize what we are doing. So in the case of what we have to do in the reforms, we have to set targets, considering benefits and costs, and prioritize interventions within the health sector as well as under the programs within the health sector. We cannot achieve all simultaneously, but I find it very interesting that you are thinking about interventions at this point, and suggest that there should be an attempt to, when you are suggesting the interventions, to actually tell us what interventions should be done in which order. Safeguarding the poor, because free healthcare alone is not safeguarding the poor, and it's not ensuring equity. There is enough evidence to show that many of the poor are pushed into the private sector. We call it the push factors, having to wait for long time for their very urgent heart surgeries, or being unable to get the drugs from the public hospitals. They necessarily have to go to the private sector. So out-of-pocket expenditure is very high, and so when we are thinking about what we should be doing, we should be trying to target pro-poor, equitable health interventions. To go to the extent of saying, should we go on with free health care, or should we restrict free health care to the poor who are, and ensure that the poor are looked after, rather than what is happening now, where we have spread the free health care widely, and we have a system where we are not really looking after the poor. When drugs are not available, they are given a chit, and that chit is never even taken to the pharmacy. The cluster system reforms, I think, were a very important step taken. It would have been very proactive. It would have been helpful to the poor, because it was low cost of treatment for patients, because they would not even have to spend very much on traveling. It was close to them. And it would have also reduced health system costs, because a lot of prevention would bring down costs of treatment. But unfortunately, the cluster system has not been undertaken proactively. It is not widely used, and this is another aspect I would like to focus on. So those are some of the ideas that came to my mind as I read your paper, Dr. Palitha and Dr. Saroj, and I thought I'll share them. Thank you.
Thank you very much, Professor Amala. You touched upon human capital, PHC reorganization, focus on well-being, and the good thing is that NCDs are not rich countries problem. Not only that, I think when you take the South Asia, there is some degree of preponderance towards the NCDs, especially IHD. This preponderance was well established some times ago. So I believe that Dr. Susi will have to talk a lot. Especially I kept the last thing, because there were areas that were not touched upon. And but before that, I would say that this PHC, primary healthcare services reorganization. Now we have these two arms, curative and preventive. But the attempt was, there were two projects, the World Bank project and the ADB project. And of course we wanted to sort of, harmonize both of them, because two projects were on PHC, but going on different roads. So we did, to a certain extent, get them together, and covered almost the entire island. And the idea was that at the primary health care level, you get this curative and preventive arms together. So then, as lastly Dr. Amala said, that will certainly, one thing is you spread the coverage, increase the coverage. And then the NCD being the highest burden of disease, that will be the huge advantage. And on the other hand, it will reduce cost enormously. And then it will also, of course, we can't impose gatekeeping in Sri Lanka as it is now, but then it's pseudo kind of gatekeeping, and then it will reduce bypassing of the lower levels, and then I think mostly the perception of disease among the public will go up. So that is how we started. I'm sure Dr. Susi know how to answer. If it, as Dr. Amala said, if it has not really given the dividends or went out of its context, it's very sad, because I remember that we came across certain resistance at the initial stages, but when we coped up this resistance, and then we moved ahead. But I don't know, the COVID would have hit, and then the economic downturn or whatever. So anyway, this was a real chance for Sri Lanka to come up in health services had this PHC taken a correct path. So over to you, Dr. Susi.
Yeah, thank you very much. Thank you very much to the foundation for inviting me to be a panelist and also to comment on the issue paper. And you don't mind me sitting here, right? Because I don't really have any slides to show, but I went through very brief, yeah. So I went through very quickly the issue paper, and as the authors correctly mentioned, that these issues have been coming over and over again, the same things, right? And the answers also, some of the corrective measures are proposed. Right, and we seem not to be doing much. There is some improvement, but we haven't done adequately. Now, being the optimistic person I am, that is why I came, because I'm very keen that something should happen, especially since we have a good health architecture, but it needs to be tweaked. That is what this reorganization policy on UHC meant. But it doesn't only mainly focuses on the primary curative care, but at the time, I think Dr. Samaragesa, you would recall, I joined the Health Ministry Policy Unit when Dr. Samaragesa was also there as DDG Planning. And in 2009, up till developing the policy, we took about 10 years after doing a lot of small scale studies and discussions, and a lot of people were involved in identifying what this reform should be. So we did not want to mess around and disrupt the preventive public health service too much, because at that time it was well supporting the system, and that is where the resilience is coming. We have to understand that we have to have a resilient health system now, especially now. not only pandemics, economic crisis, everything. So when we cannot afford too much, we have to build in the resilience. The resilience will come if we can, resilience is dealing with the shocks. Economic shock is one main thing, and I think the primary health care, and that is making available this care closer to home, is what is important. Right? So in order to do this, we have to understand why this reform also, or this change that we suggested, despite having two powerful banks supporting these changes. And I am not saying that nothing has happened. Actually, there are maybe if we invite provincial directors and regional directors to speak, and they will tell that there is a lot that has happened, and probably the ministry has not measured it in that sense. And probably we are using the wrong measurements also. So we have to really think of holistically, have we used this reform? Now, aging. Have we used this reform for aging? We were talking of the reform change to address non-communicable disease. Right? But there is a lot more other things that can be utilized. So if you analyze the reform, and I think the human resource, right? So there are a lot of things in this issue paper that is telling about the problems, the issues the system is focusing on. But I want to ask the authors also, when we look at probably the data and all of that, you may be relating it to the data that is probably just before this economic crisis, right? And how we are going to deal with the problems now may be slightly different. And also, I think, Anuji, you mentioned about, it was mentioned about the catastrophic spending. And I think now in 2 days' time there is going to be a discussion on this self-financing policy, strategy they call it. But now we have to understand this catastrophic spending is, it's gradually now increasing, right? And even impoverishment is gradually going up. It's not alarmingly going up, but it's going up gradually. But if we are to continue to have our system as a safety net to the people, how do we protect it? How do we keep this out-of-pocket expenditure low? Right? And we don't know right now, we don't know. The middle class, or if you put it into class even, a lot of people are not accessing health because of the high expenditure. We have not assessed, none of our studies right now, we don't have any data on that. So the recent discussion, we were at a meeting on this Prince Mahidol Award conference, and they were talking about financial protection, not in terms of catastrophic or impoverishment, but health that is not accessed. Foregone health, they call it. Measures of, not accessing health because you can't afford, or swallowing one pill instead of 2 pills. Right? Not turning up for screening because now it may be, transport, you can't go, things like that. So this is why the package that we are offering, in fact, the essential service package is documented. It's already done. The Health Ministry has done it. It's published on the web, right? We need to see now what we are going to, really look, whether in terms of aging, the nutrition and all of that, we are in some kind of a nutrition crisis also, right? So we are in a kind of a transitioning state where we really don't know what is really going to happen, the health, condition. So this is why I think Professor Amaldi, she mentioned about well-being, and I think it's put as an issue in the issue paper also, that we need to focus on the well-being side of it. And this is, again, primary health care, right? The thing is, now we need to cost not only the medicines, not only the salaries, but if you want to invest in well-being, we need to see how we're going to do that. Do we need to retrain our doctors? Are we having the doctors who can do this? So this, person-centered care, right? Whether we can, whether our doctors now understand the patients, and they can give person-centered care, not only managing the illness part of it, because that is what you are expected to do. You are expected to prevent something and prevent something happening in that family also, by virtue of the fact that the patient or this person comes to the closest health facility, and you have like a family doctor kind of a person now in your primary care. That was the whole idea of the reform. So we in the health ministry probably overlook that. It's not that it's not there. The policy document actually has all of that, even a strategic framework attached to the policy. But when we are having two funding agencies providing funds, this is why the resource mobilization, we have to stress on this. We are pushed into ministries taking the seat to monitor those projects and not monitor what we need to have. So when after a 10-year analysis and all of that, when you identify what needs to go, policies, and when projects are monitored in steering committees and forgetting the rest of it, because that program those projects did not look at human resources. They expected, that is the government equity to the project. The human resources will be provided. Usually, projects come in like that. The government has to provide the human resources to implement the projects, right? But this policy clearly needed a change in the quality of the workforce. And the projects, when you monitor projects, it's only the project indicators. So there is a whole host of things. If we wanted to change the outlook of the whole primary health care to achieve universal health coverage, you have to monitor. So that's the governance side of it. The monitoring part, monitoring what, all of that needs to be identified. So this is really the overall, when you look at what is happening in the country, when you think of the other things that were spoken of, Dr. Abeykoon mentioned it, all of those things that are happening in the country, there is a cultural change in the health system probably needed for accountability. So, the whole health management, the health administration, the leadership, all that, that's a governance side of it, about accountability. We don't have audit systems in the curative sector. Apart from maternal death, all deaths are audited, but not living people audit, The life is not audited, but debts are audited, something like that. So we want kind of some major changes are needed. So as you said, sir, Dr. Samarge, sir, you mentioned, yes, we have to get into the causes of the problem. So the causes, changing the governance structure is really something that is needed. But that's going to be the most difficult one, because there is resistance, and that is where the transformation will come. And probably the voice and all of that is important to bring these changes. The social participation is important for change. I think there were a few more things, and I think there was one other thing, health technology assessment. I think, I recall, whenever there was some training program or anything related to health technology assessment, the usual thing is for the ministry, we would think, now under whose directorate does this subject come under? So the word technology. So there is a directorate for medical technology and supplies. And you can imagine the understanding that is there on what health technology assessment is. So actually now, of course, there are several academic institutions bringing up training on health technology assessment, but there is a divide between academia and implementation. So there's another avenue of work focusing on implementation science, that is the research for implementation. So that's very important. So these things, now there is no point in only delivering courses. Now we have to follow up and really see whether those who were trained, have they really done something. This is the kind of follow-up that is needed now, right? We have to now see. There's no point in just training somebody. You have to really see whether they have made use of that. So that's also another kind of governance, the accountability on follow-up on whether the training was right and it suited the purpose. So this divide between academic and there's a whole body of academics that we need to really now pull into improving and bringing about the transformation. But I think the issue paper has highlighted briefly on this and needs to probably elaborate more on this area. I'll just stop there. Thank you very much.
Thank you, Dr. Susi. I think you spelled out on governance and then, of course, the correct measurement, stock taking, monitoring, evaluation, and certain things happening in the field, but the ministry is not taking stocks properly. And but having listened to all of you, I see that the allocative efficiency and technical efficiency are two very important aspects in the healthcare service, not only healthcare but even other services. So thank you very much, panelists. Now I would like to open this forum to the audience, otherwise we don't address equity. So we will. I have been listening to that. So you can pose your questions to experts and to presenters, not to me.
Yeah. Just before we start the Q&A session, just a bit of a point. If you can introduce yourself first, and then if you can make your questions brief and to the point, we will really appreciate that, because we've run out of time. Thank you very much.
I'm Linokus. I'm a journalist. I just like to have one clarification. Does a person's ethnicity or race have any impact one is accessing of health outcomes in this country. Dr. Kamage may be able to answer that.
So we have a wide network of institutions throughout Sri Lanka, from primary care to tertiary care to specialized institutions. You can't access outcomes, you access services. So considering service access, I don't think there is a inequity. Well, there might be geographical variations, but it might not be affecting ethnicities. Of course, I have not analyzed to see this. Madam, do
you? To answer the same question, ethnicity comes in with sometimes with the language barrier, but there is no sort of any policy level. There is no discrimination at policy level or in the provision of services, but at the individual level there are issues coming up with the language barrier, as well as sometimes socio-cultural issues which limit people coming to the health system at the right point. So the ethnicity plays a role in that way.
Yeah. Now, if you take the way we have described according to the demographic health survey, that is, we have the DHS survey supposed to be conducted every 5 years, but the last one was in 2016. So we analyze according to urban, rural, and estate plantations. But of course, you can also look at whether the health outcomes are different between the districts, or even sub-district level. So there are various ways, but it is usually our public health system that we have these indicators that we analyze. But unfortunately, we don't have so much of indicators for the curative sector, whether these are different. So, but if you look at maternal mortality rates and all of those, so there is a slight district variation, right? But there is no wide disparity. So there has been a gradual narrowing of these disparities over the years, which means health access has improved. But if you look at the health workers, and that is what I think Professor Amala was mentioning about the language barriers and access. Because see, a lot of health education and so forth, it's communication oriented, and in some of the Tamil-speaking areas, especially for the estate populations, we do not have enough health cadres. Now, one important policy decision that was taken by the government was the plantation sector had their own hospitals, right? And there were EMAs, estate medical assistants, who were really not doctors, right? So, but we took a policy decision, to acquire these and integrate this into the general health system. So what happened was, there was initially the public health system, and up to now all the plantations are now merged with the MOHs. So it is the MOH and the public health midwives who now provide the preventive health services for the estate population. So there again the issue of the language sometimes comes in. So there have been a lot of development partners helping us with the language issue, training, and different things. But then when we transfer the health workers, then again you need to retrain that. But the curative services, again, we have not taken over all the estate hospitals. So, but basically we are linking them up with the available facilities. So there is a lag in that. So, but by far and large, the health outcomes, there are subpopulation disparities. Now we are seeing it for things like, if you take leprosy, there are pockets of leprosy. Then, but due to different reasons. So this is now, I think this is all about, once again, improving the level of the health literacy in the population. There's this much that the health system can do, but there's more that can come from the education system. So even for health, we benefited a lot by female empowerment, female literacy, the family literacy, access to health improved, immunization access, all of those things improved when you improve the education. So again, there is a lot of things to be done through well-being and improving the general literacy of the population. So obviously there's going to be challenges for that,
Can I respond to that about the language issue? I think there are some issues in relation to communication in some of the areas. But if you look at the teams in the hospitals, invariably there will be someone who will be able to intervene. So it's not a major barrier. I don't see it as a clinician. It's not a major barrier, language. In relation to language, the more important point is that drug labels, prescriptions, etc. are given in English only. That's the discrimination. And there's a Supreme Court case now to get the NMRA to ensure that labeling of drugs happens in all 3 languages. And the pharmaceutical industry is contesting it. So I think that's where the public should put pressure on. Because the barrier, I think, is in not using native language in our health communications. If you look at the drugs, the labels, you go to the pharmacy and look at the labels, it's all in English. Patient information is only in English. The drug labeling is mainly in English, just a few drugs only which have all 3 languages. So we are basically keeping our people ignorant because most of them cannot read the English words. That's why patients come and tell us, Manganne Ratupeti, Sudupeti, Raumpeti. They describe it because it's not labeled anywhere. And when it is labeled in English. So that's an issue. And as for ethnic differences in health outcomes, in certain things there is a difference. Especially as regards to obesity, some of the community-based studies have shown in certain ethnic groups, obesity and diabetes is high. And it happens to be in Colombo, certainly in the urban areas, in Colombo area, it's the Muslims, especially Muslim females. And we've been telling some of our Muslim colleagues, use the mosques somehow to get this message across about intake of carbohydrates, highly refined, sugar and so on, and importance of physical exercise. So there are ethnic differences in particular diseases and disorders. Yeah, thank you.
Thank you. I think this gentleman, 3rd row.
Thank you. I'm Dr. Rajiv, working as a consultant with Asian Development Bank. So my question, I saw in the issue paper, it's a very good brought out issue paper as far as issues are concerned. But from the solution point of view, one of the issues which was raised about the potential synergy between public and the private sector. This is one of the solutions broadly proposed. So in the panelists' opinion, what are the key areas where the panelists think that these are the kind of entry points or maybe synergy points where the public and private sector can, kind of some partnership or some forum or some alliance can be made to cater to the overall objective of whether universal health coverage or the overall health sector objectives of the public sector?
I mean, Rajiv, something I see it like this. If you take it at a very macro level, there are a number of things you need to do. I mean, one extreme would be what, for example, Thailand has been able to achieve, where there is no difference in the private or public sector with regard to the government is purchasing services either from the private or from the government. So now Sri Lanka, we don't do it. The government doesn't purchase, purchases quote unquote from the government sector only. Because for number, it's a long conversation, it's a topic for another seminar at that level. But lower down, you see, one of the things that people have been suggesting, I am not suggesting, but I observe it, I can explain to you in my mind what are the pros and cons. For example, now there is a lot of spare capacity in the private sector during daytime, particularly for surgery. There is a big, heavy demand in the state sector during the working hours for theatres and theatre time. Right, Ratnaji? Even at Sri Javardhanapura. So one suggestion, and this has not been explored in detail because there are many managerial issues that need to be sorted out which go beyond the health services. The use of the private sector in some way, some relationship, either on a case-by-case payment, to use that space, using government surgeons, etc., to deliver the services to reduce his workloads and the waiting list. Now that's the third level, of course, at the very, what you say, the meso level and the micro level, there are a number of little things you can do it at the micro level with regard to pharmacy, laboratory services. Now, for laboratory services, we can do the same thing. You could contract the laboratories even in this the cluster system that we talked of. When there is no laboratory close by in the there is no government, so with the government hospital with a laboratory, you could always get a couple of private labs to do that on a contract basis. So there are many levels at which, but unfortunately, correct me if I am wrong, we have not explored any of them in depth. Now, even now what's happening is you go to the government hospital, you go to Colombo hospital, his ward, or his former ward. There will be people in the ward who refer to the private labs right round. Otherwise, there is no need for private labs to be right round the Colombo General Hospital. So it's a very complicated thing. But my sort of frustration is that we don't look at these and analyze them deep enough to find some solutions which are available. We take the easy way out and say, oh no, it's too much, not having enough resources, we need, that is all that is true. But even with the resources that we have, if you increase the efficiency 20%, we can purchase much more services than we have. So many things that need to be done, but when are we doing that? I don't know.
Okay. Anybody else to comment?
I got a couple of questions. One is when drugs are imported into the country, isn't there any quality control and efficacy and those things are not checked? Because we had a problem with this immunoglobulin very recently. That's one. And the other thing is when importing drugs, is the Minister of Health supposed to visit those countries? Because the ex-minister visited India, I think, when it came to importation of drugs. And the other thing I want to know is that at NMRA, I think some data went missing and records and all that. But was any punitive action taken against those responsible?
I think it's health technology part.
But I think if you go through the HTA process, there can't be things like this happening. Because it's a process where there are many chapters. First one is safety and efficacy, whether this would work in my country. So that is a systematic review. Somebody asked about HTA, whether this is a complicated process. No, it's not complicated. The name is complicated. The first chapter is a systematic review. The second one is economic evaluation. The third is we consider about ethical and justice and social issues. And the fourth one is you do your policy recommendation. So it's not that difficult. The name is difficult. About this NMRA process, I know, sir, that it is a very, they do it thoroughly. And when companies compete for technologies is not just drugs and pills, and it could be screening programs, it could be buildings, it could be vehicles. Anything that we use to promote and prevent ill health, prevention and promote health. So then it is the companies who give us these reports. They talk about safety, and I know about quality control. There are, so SPC, NMRA, I don't know where exactly they do. So there are places where they look at quality when it is brought down to the country. NMRA is a very strong place. I always tell Sri Lanka, it's not that we don't have HTA. We have several, we don't use the name, but I must emphasize that we don't go through the whole process. There are little bits and pieces. Yes, anything else that we can add on the same issue?
To your question directly, if you ask me, is there a procedure in the NMI? There is. And the system is a little bit complicated, but it's in a way straightforward. When when a company hands over a dossier to the NMRA to be evaluated to import a drug, to get it registered if it is a new one, and to get a re-registration, there's a very serious process that goes on. I mean, the quality control that have been done in the country of origin, the data about the usage of all that is in the dossier. And then we have a lab in the NMR itself that is also doing the quality analysis. The problem with that lab is capacity is very limited. So if you have lots of medicines of different brands coming to the country, that lab cannot cope to do everyone. They do about 25, 30 a month. So it's not enough. Now we had a proposal to get a few other labs, non-NMRA labs, accredited to do the same thing. But that has not happened. Now, so therefore, the answer to your question is there is a process. But sometimes, there are slippages. That is a problem.
Thank you. Can we have the last question or comment?
Thank you very much. I'm Dr. Ratan Sirihevage, Director, Sri Jayawardenepura General Hospital. I just want to mention that, I'm managing a hospital, very small hospital, 5.7 billion, roughly around that, amount. We are given 2.5 billion from the treasury, and the rest we manage. And because of that amount is given for the salaries, we are giving at a very low cost to the patient. Because when we compare, say, appendicectomy, when it is done in the private sector, it's 5 times higher than our normal charges. And then you come into the, we have our private sector also. That's why, this is one way of, thinking, strategizing, and to improve the, efficiency by giving the decision making to the operational level. So we are being given decision making rights. We have a board and we have a right. We don't need to go through the secretary and of the ministry or anything. We can have our own decisions. Our act is very powerful. And I think my suggestion is, sir, now we need to, so when I was the director of LLDGA Hospital, I used to issue a bill that will reduce our costs. Say, overheads reduce remarkably. Just Dr. Professor Amala knows, and she was involved with us, and it reduced the wastage. It's reduced, and because just giving a bill, and it was parked as, is trying to privatize it. It didn't happen, but it reduced the cost to the government. It's public money anyway. I think, the one way Dr. Susi is making, you should not grab all the governance into the ministry. You have to delegate. You have to give the accountability to the people who manage the hospitals. And then, because the circumstances are different from the, north, east are different to, southern, Colombo is different to Goal. Okay, a lot of areas are there. But if you give accountability to the person who is managing the hospital, then he is supposed to manage. That's the way. Otherwise, no. Otherwise, nothing should be done. Just give the responsibility to the operational level. That's it.
Thank you, Dr. I'm sure, Dr. Loitman, you will have the last word.
Yeah, my name is Dr. Lloyd Fernando, but doctor is Dostara Neme. Acharya. When I go to hospitals, I see to it that nobody calls me doctor. I want to thank you. Fantastic. See, I learned a lot from you, but we won't just let you go. We are going to get you engaged with us. We are going to take forward all your ideas, not only this project. You see, we have identified 20 sectoral areas, and we have studied those, and we have subjected them to discussions like this. And what we do is, so after, just imagine, now you came out with such nice, very important issues, you see. And so if we just let you go and not take note of what you have said and don't communicate that to the government, it's useless. And government means, you see, to tell you frankly, you see, I have a reputation of being in government for a long time. Before some of you were born. And then what happens, because of that, some of these politicians know me. And they keep on asking me this, that, and the other. I tell them, no, we will meet all the politicians, all political parties. We can't, you see, show any preferences. And so I have devised something where we will bring the politicians together and have a good discourse. But we will focus on a fundamental issue, because otherwise we'll just talk and go, of issue of national planning. All these things must finally get into a system of planning. Then only things will work. Otherwise, you see, because we have to have a holistic approach to the problems that we are facing. You can't intervene piecemeal here and there. You know, you have to have a holistic view of the problems and then have a system of planning. And of course, a lot of people that I spoke to me say, oh yes, we are for planning. But they must also know that planning means a commitment. So, in March, I hope, if everything goes well, we are inviting people from all political parties. Each political party to send 3 or 4 people to the discussion, and it will be held here at the BMICH. And then they can tell us what they think. Then they'll commit themselves also into following up. You see, today what happens? Every time a minister changes, not only the government, minister changes, lots of changes take place. So because of that, we want to address these issues in a systematic manner. And until and unless you incorporate all these things into a system of national planning, nothing will move. Where health sector will be in the national planning system, and also we'll have a separate segment on health, bringing in not only government people, private sector, NGOs, all those people will be brought in, and international organizations, so that more detailed discussions could take place among them. And that system will work. But we'll keep you informed and also engage you. You see, you can send us when you go home, and if you feel that you have not been able to speak today, well, you can see because of the time constraints. But we would encourage you to write to us. See, we will take note of that, because there will be groups studying what you have said. And then we will also communicate that with our diaspora. I'm encouraged by lots of things happening with the diaspora organizations. One of our colleagues in the diaspora group has got an international award in the US. I'll let you know. And it's called some award, lifetime award. I forget his name. Yes. But anyway, just to say that the diaspora is interested. Now lots of people or doctors are going away. You can't stop. Because it's not just a question of salary or anything like that. It's much more issues. They are thinking of the future. They are thinking of children. You see? So we can't meet all those challenges. But they would like to be involved with us. That we know. And that's what we have been told. So we'll find a way of getting them involved. We'll ask them how. Now all these issues, as I said, will be put into a package and then made available to them. And they can tell us, oh, this is how we are doing it here in the US. This is how we are doing it in the UK. You see, our biggest supporters are from the US. That organization is US organization. And then we get support from Australia, Canada, and New Zealand, apart from UK. And many of them, interestingly, are those people who studied in Russia. But they can't work in Russia. They have got some superb qualifications which are recognized by those countries. So they moved out, but they all feel for the country. They would like to be involved with us, so we have to find a way. And we'll consult you. You see, this is what I want to tell you. So when you go home, don't think that we will forget what you said and your involvement today. So I just want to tell you, while saying thank you to you, to tell you that we will be in touch with you. Thanks, sir.
Thank you. Thank you, Dr. Lloyd. I think you are referring to Dr. Jawahir, right? Were you referring to Dr. Jawahir? The lifetime. Yeah. Right.
Yeah, I was just wondering, because now elections are coming in. Let's be practical. There will be manifestos by the different political parties which are going to come up. Is it possible for the foundation to pick on certain key areas, education, health, social services, or poverty alleviation, and a few, not everything, just a few, so that there is consensus in the political parties before they come to elections? You see, if you listen to what is happening, whenever there is a policy, the system is such that it's an oppositional system. So if ever you say something, it's opposed. I mean, I can argue and say that you should not be standing, and I can argue and say you should not be sitting. I can do that with medical knowledge. So similarly, the politicians also, that's the strategy they are using, because it's an oppositional system. So is it possible for us to pick out certain key areas and at least have some consensus which will go into their manifestos? Because I see this as a super tanker. We can't move it. You know, the super tanker is moving slowly, and even if we make a 1 degree change, the destination is going to be different. Suggestion, sir.
So,
you have been able to read my mind. You said exactly what
thank you. I think we should not be sitting anymore, right? So we must get up and get out of this place. So let me thank once again Gamini Korea Foundation, the Deputy Chair, the Dr. Lloyd Fernando, Sohan, who was actually thick and thin working on this, and of course the 2 presenters and the panelists. And I also thank for inviting me to chair this session. Over to you, Sohan.
Thank you very much, Session Chair Dr. Anil Jayasinghe, the authors, Dr. Professor Saroj and Dr. Palitha, and also I would like to thank our eminent panelists. Just before we finish, I would like to take note of the next session, which is session 17 on international trade and development and FDI Sri Lanka, which will be done by Dr. Ravi Ratnayaka on February 14th. So you're all invited to come for this session. And last but not the least, there is one very important event.
ලතාවක් ගැන කතාවක්. ඔබ දිරයෙන් දිලිඳුකම පරද වූ කාන්තාවක් නම් කියන්න ඔබේ කතාව මුළු ලොවටම ඇහෙන්න. හමුවන්න කතා රචකේ රචකයිනි. මෙවැනි දිරිය කතුන් හඳුනාගන්න අභියෝග ජයගත් ඇගේ කතාව ලියන්න ඔබටත් ආරාධනා. ක්‍රීඩා කොරයා සම්මාන උළෙලට ඔබත් සහභාගී වන්න. හොඳම කතාවට ඔබ දෙපළටම වටිනා ත්‍යාග. ගාමිණී කොරයා පදනමේ ව්‍යාපෘතියක්. පිවිසෙන්න GaminikoreaFoundation.lk.
So the Frida Korea Award ceremony will honor inspiring women who have overcome poverty through family empowerment, and their stories will raise awareness through the award ceremony. And this will be held at BMICH on the 15th of February 2024. Thank you very much, and have a good evening. Good day.
ලතාවක් ගැන